Good afternoon, everyone. So today my topic is how AI could hear the echoes of suicide. You must be wondering, what is this topic about? I'm here to explain that today. As a psychiatrist for over 20 years, I've seen thousands of patients in clinic, in the wards, in police cells, in prisons. And there are two words that terrify me till this date, especially when there is no underlying context. I'm fine. Let me explain it further. I would like to introduce you to my patient Tom. Tom is in his early 40s. He is a hardworking, intelligent, committed board director in a well-reputed company. The board had noticed some changes in his behavior. It was getting unpredictable. He was getting more angry, more irritable. The team was fragmenting, and there were some staff who were leaving their jobs. So Tom walked into my clinic and he said, "Doc, I don't want to waste your time. I don't want to waste my time either. I'm here just for a letter. Just give me a letter, I'm fine. I'm normal, there's no problem. And I'll go." I said, "Well, Tom, I can give you a letter. That's okay. But I need to assess you first." You can imagine his reaction. He got furious. He stormed out of the room. He left the hospital. That day, I didn't see an angry Tom. I saw someone in denial. But I never thought that would come to haunt me later. 3 months later, Tom comes back to the clinic. So when he is ringing my secretary for an appointment, she's given one, and then she's asking me, "Should I get the security? Because last time, can you imagine, the situation was a bit risky. So just in case." I said, "No, it's all right. We can manage. The fact that he has come again means something." So I said, I can see him on my own. So he walks into my clinic. He was quiet. He was calmer. And suddenly he became very emotional. And then he said something that sent a shiver under my spine. He said, "I'm suicidal." I was shocked. He said he didn't see it coming either. He got very tearful. And then he started telling his story. After the consultation, we were able to identify his condition, what may have contributed to it, and you must be wondering, what is that condition? He was suffering from a depressive episode. And this is very important because we always think depression is about feeling sad, not eating well, feeling very emotional all the time, not sleeping. Not necessarily. Depression can present in various forms. So in Tom's case, he wasn't depressed for months or sad or losing sleep. His main problem was changes in his behavior. So we worked out a clear management plan, including therapy, which he was willing to try. He engaged quite well with the therapy team. And it was amazing when I saw him in clinic. There was a remarkable recovery in 3 months. He came to the clinic saying, "Wow, that's an amazing feeling. I can see colors. I can hear the birds singing. I can see the rainbow. I can see the flowers. I can see the fields. I can go for walks. I feel so happy. Why did I not notice this earlier?" And this was a picture taken by him during one of the walks. And here, if you look at the bottom, he described it. He said that dark pit, the mud, that's where he was for years, not realizing that he may be suffering from depression. And then, as you can see, he said, I've come up now and I can see the colors. That's who I am today. He was so grateful that he even prepared a collage of, colors, butterflies, flowers, walks in nature, going out with friends, his family. His bonding with the kids improved, his relationship improved, and his work colleagues were so impressed that they gave him a promotion in 6 months. And my therapy team were like, wow, Dr. Arokia, he is your model patient. He didn't miss a single therapy session. And in fact, he said in one of my clinics, he said, you should bring a recorder and you should record what I'm saying. So you should share it with the audience. You should show them that depression is treatable and people should seek help and get better. It's a shame I didn't record it that day. But at least I'm sharing his photograph today. So after 3 years, I get a call from the clinic. The early hours of the morning, Tom had committed suicide. I was shocked. What's happening? He was doing so well. Where did it go wrong? Did I miss something? And my team were like, the therapy team were like, did we miss something? Because they had just had a session like 3 weeks ago and he was fine. He was doing well. His family were wondering what happened. His parents were shocked because he just had dinner the previous night with them. His work colleagues were shocked. Nobody didn't know, like everyone were asking the same question, did we miss something? Actually, we humans, we didn't miss anything here, but we need to acknowledge the limits of human observation. Even the best risk assessment tools, the best clinical judgments cannot predict certain suicide events because it can happen even when you feel well and normal. And I'm wondering whether Tom himself was able to pick that up the previous day. Why does this matter? Suicide does matter because there are 3 categories where suicide carries a huge risk. One is the younger age group, as you can see. The second largest contributor to death in this particular age group is suicide. Can you believe? The second is similar to Tom, 40 to 54. And the third is the 70 plus. The elderly, parents, grandparents, because of social isolation. Since, grandchildren and children are more busy with, their mobile phones, they hardly get time to spend with the grandparents. So just going back to Tom, could AI have picked up any of those risks? And from what we gather from recent studies, AI is good at picking up subtle changes in behavior, subtle changes in sleep pattern, subtle changes in color perception, specifically in Tom's case. That's what we call personalized care. Changes in the quality of the text messages, whether there is a lot of I'm fine, the timing, the frequency, and also it can predict any reduction in social attendance or social withdrawal. In a larger scale, if we were to apply this, AI has shown to be good at screening, especially when patients are in waiting list. Currently, there are about 400,000 patients waiting to see a secondary care specialist in the NHS today every month. So if we had a second kind of AI assistant to just help us to observe those changes in their sleep or their mood or sudden dips, in their mood or appetite, they can bring those patients to our attention whilst they are in the waiting list. It may help to triage better. There is also increasing access and confidence for patients. How does AI work? So when it comes to mental health, how do you think AI might work? Yes, it's picking up patterns, subtle patterns and changes in behavior and mood and sleep and appetite. Fine. Can it do more? Well, it may. Currently, if you take a patient waiting to see a consultant psychiatrist, already they have waited for months or maybe more than a year, and then they walk into the clinic, so they are so anxious because they are seeing their specialist for the first time. They don't know what this whole consultation is about. They don't know what questions will be asked. And as a psychiatrist myself, when I delve a bit into their past psychiatric history, family history, their developmental history, history of bullying, they are like, I'm not sure, I don't remember, this year or, and then, they get a bit more anxious because they feel under pressure because the consultation time is about, say, 1.5 hours because then the next patient has to be seen. If part of this assessment can be moved to outside the clinic, even before the patient comes and sees the consultant, he or she would have completed the assessment in their own time. They could have taken breaks. They can complete it at their own convenience. And when they then walk into the clinic, they come as equal experts. They are not victims of mental illness. They'll come and they'll challenge me. Doctor, I've done this assessment. I've read a little bit about it. This looks like, I'm not sure, it could be bipolar, it could be schizoaffective, because there's a lot of symptom overlap. What do you think? That's what we need to see in mental health clinics today. I would like my patients to come there as experts and challenge me. And I think AI would give them that opportunity, which they shouldn't be denied of. Whilst AI can be quite promising, there are also some red flags we need to be aware of. There are some unregulated, unapproved, unaccredited chatbots out there, and it's very difficult for us to distinguish between which are the regulated ones and which are the unregulated ones. I know currently the systems are working on it, but as of yet, it's really difficult to distinguish, to make that distinction. So unfortunately, whilst people are waiting, for months and years to see a specialist, they are desperate. They need help. They may be like Tom, feeling suicidal and desperate for some advice. What do? Go to ChatGPT. And sometimes the advice is not good. And we know that people have also, ended their life listening to unregulated chatbots. And the other risk is they can also develop a kind of dependence. So every time there is an issue, they go there, put in their problems. And then at some point, they kind of develop a dependence. When that dependence is too high, and then when they get messages, say, from friends or work colleagues, they'll be like, oh my God, that text is very similar to what I saw. So maybe there is a link. They get a bit psychotic. And this year, there have been cases of AI psychosis as well. So I think this is where our accountability and our responsibility comes in. We need to make sure that we use AI for the right task. Like, for example, pattern recognition. A gentle intervention, a gentle reminder. So say, for example, if Tom had a reminder that day, this pattern, your sleep, your mood, your text messages is very similar to what you experienced 3 years ago when you felt suicidal. So maybe reach out. Yeah? So I think we need to look at a new partnership here between humans and AI. So the choice is ours. We need to decide whether we allow AI to augment what we are doing. Like, for example, if AI is allowed to take over all the admin tasks, I will be able to spend more time with my patients. If AI is able to it's not for substitution, strengthen. If it can strengthen what I am doing in terms of, say, picking up subtle patterns, I will be able to spend more time with the patient, showing empathy and compassion. And that's the core of mental health. That's what AIs can't take away from us. And it's important that we use AI for some of those tasks so that we are allowed to spend more time in what we are actually trained to do, in what we are actually good at, and in something that cannot be replaced by anything else. So we have a choice to decide what we use AI for. And if AI can pick up those echoes of suicide, those fears, and if that can save 1 million lives from breaking, why not? Why can't we choose AI, and why can't we decide where it would help us, where it would assist us, so that we will make sure that nobody comes to a consultant psychiatrist in crisis. They come to us much in advance. And thank you so much for the opportunity. Thank you for listening.